So basically, to start with, the the SPECT MPI was the workhorse for the nuclear medicine department, and with now growing PET scanners available because of the growing oncology centers and increasing availability of newer traces, we are able to talk about the PET MPI. So, which has an advantage of doing quantification like myocardial blood flow, myocardial perfusion reserves, and it simultaneously we can get the data of MPI, MBF, MFR in one single steady increment without any incremental radiation exposure or the cost. So, but with the available SPECT traces, they are inadequate for the challenge for the quantification. So now as I discussed, the PET scanners are now widely available, almost more than a dozen of PET scanners alone in Hyderabad, and number of gamma scanners are coming down in a paradox. And many studies are reiterating the advantage of PET over SPECT in quantification because of its added value of quantification. And because the reiterative the reconstruction techniques or the processing softwares, everything have shown a great advancement. So like, what are all the quantification parameters we like? It is myocardial blood flow or myocardial flow reserve, the tissue perfusion, the perfusion tissue fraction, and perfusion tissue index. So all these parameters can be studied with the quantitative PET. So what are all the traces available which can actually be used for either MPI or PET? So the technecium-based traces are all for the SPECT, like the technetium system-AB, tetraphosphine, which are most commonly used. But whereas the thallium is not very commonly used because of its inadequate the gamma energies and the increased radiation exposure and logistic issues. But coming to the PET traces, if you see the rubidium 82, N13 ammonia, and O15 water, all these are the traces which are used for PET myocardial perfusion. And if you see the radiation exposure, the PET traces have significantly lesser radiation exposure as compared to the PET, as compared to the SPECT. So I want to draw your attention to different traces available, and their half-lives, which is going to determine actually the how the logistic issues which are associated with these PET traces. So if you see the O15 water, which has very short half-life of only 2 minutes, and if you come to the ammonia 13, which has a short half-life of 10 minutes, and rubidium is, of course, a generator based, but these two traces are cyclotron produced. So you need to have an on-site cyclotron to do this, to do the PET perfusion imaging with these traces. But coming to the rubidium, it's a generator based, and you have a generator which has a half-life of 25 days, and it can go for 1 month, but the significant cost factors are associated with it. And then the newer tracer, which is showing some promise, is the F18 fluorpyridaz, but it is still in the ongoing second phase 3 trials. So if you actually see the half life, that itself is a confounding factor for usage of these traces. Okay. So what are all the quantification which is the ideal tracer for doing these quantification techniques? If you see, the ideal tracer is O15 water, which has very short half life of 2 minutes, and and the fluorpyridaz and ammonia. So the other traces, the SPECT traces are very the first pass extraction is very less. So the perfusion, if you compare the flow to quantify the myocardial blood flow, you need to have a good first pass extraction, which can give us a good quality images and for quantification. And if you see the other part where the uptake of these traces into the myocardium, see, the O15 water does not have any uptake. It is just the perfusion agent. It's only freely diffusible, and it cannot be used for an MPI. So, but it is an ideal tracer for quantification of myocardial blood flow reserve and other parameters. A similar slide. So as I discussed, because of its short half-life, but it is freely diffusible. It has 100 close to 100% first pass extraction, and it has a very minimal radiation exposure, both stress and rest put together. Similarly, the rubidium also has a very small radiation exposure. Because of the short half-life, we can finish off both stress and rest images within 30 minutes, because of a short half-life, because of its washout. Similarly, to the oxygen, O15 water. But if it come to the ammonia 13, it has a little longer half-life of 10 minutes. So the both stress and rest perfusion, we need to have time gap between the rest and the stress. But the radiation exposure is similarly very less as compared to the SPECT traces. So coming to various studies which have studied both SPECT and PET together, so they have a given clear advantage to SPECT quantitative PET in terms of the sensitivity, but when it comes to specificity, more or less they are similar, with little advantage of PET over SPECT. So similarly here, if you see the sensitivity is very high with the PET, the specificity coming is both are close, the SPECT and the PET. So this is a meta-analysis of all the studies put together for the quantitative PET. It has a high sensitivity of around 90%, specificity of 89%, and a very high positive predictive value and accuracy. So this is the image taken out from one of the journals. This is an O15 water. This was the patient who had a very normal perfusion MPI study, but when we quantified the myocardial perfusion, the patient was a triple vessel disease. It was a balanced ischemia. It showed a significant reduction in myocardial blood flow. So this is the rubidium imaging, and this is the ammonia. You can see the crisp images, very good attenuation correction and no attenuation correction artifacts. All the segments of the myocardium could be seen very clearly, and the ischemia could be assessed very cleanly. So the most commonly these perfusion traces are for the diagnosis. When it comes to, it's a commonly accepted indication, especially in case of a multivessel disease setting where the SPECT can have a balanced ischemia, and the microvascular disease where the perfusion imaging could be normal, whereas the myocardial blood flow can be reduced and flow reserves can be reduced. And the patients with a very high body mass index, because this can cause attenuation artifacts, especially the diaphragm and the anterior wall. And the PET should be preferred because in young patients, because of its very low radiation exposure. Because as I discussed, the quantification parameters of myocardial flow reserve will give additional value in risk stratification. And also, the quantitative PET is unique in its capability to assess the severity of microvascular disease. And this is more important because the epicardial perfusion, the CAG could be normal, but the patients may still be symptomatic. And in treatment planning also, because of its quantitative parameters and assessing the microvascular disease, the PET has an advantage in planning in treatment planning. And the quantitative PET can identify the asymptomatic coronary artery disease and assess the treatment efficacy as well. So hybrid imaging is, as was discussed, is not very commonly available, but this puts both data sets together. One is the perfusion as well as the CT data sets put together gives advantage of both MPI and CT coronary angiography put together. which can assess the hemodynamic significance of the defect of the vessel narrowing seen on the CTA, and similarly it can also help the MPI to assess the hemodynamic significance of the atherosclerotic plaque and its burden. So this is the again an image drawn. If you can see the narrowing and the myocardial quantification of that particular territory, which can give us at a single setting, which can assess both the CT as well as the myocardial flow reserves of myocardial blood flow. So this was one of the Pacific trial, randomized control trial, which actually this was only O15 water was used for this particular trial, and for which it has given the advantage of PET over SPECT, and in some setting in accuracy, it is better than CT coronary angiography. So PET imaging has yielded highest diagnostic accuracy of diagnosis of myocardial ischemia established by FFR. So I'll quickly run through a few of the slides of the viability assessment as well. The viability assessment, we can the two imaging is required. One is the perfusion and the FDG. So both put together, we have to assess the area where there is no perfusion. If we see the FDG uptake, then it means that it is a hibernating myocardium. So here the technique for there are two, the viability and cardiac sarcoidosis. I'll be showing few slides on cardiac sarcoidosis as well. So if you see there is a perfusion defect in this LAD territory, which shows no, this is a rest, this is FDG. So if you see there is a perfusion defect and there is a match defect on FDG as well, so there is no significant viable myocardium in the LAD territory. So you can see this polar plot which shows a fixed defect. And in this patient, if you see the LAD territory which was showing a perfusion defect, there is uptake on FDG. This means that this is a hibernating myocardium. So if you can see the polar plot, there is significant reversibility here. The reversibility in the sense the uptake on the perfusion, the perfusion defect is showing the FDG uptake. I will skip through this slides. And the cardiac inflammation here, the preparation for myocardial viability and cardiac inflammation is totally different, because there we are trying to push as much glucose as possible into the myocardium to assess the viability. Here we don't want the myocardium to have a physiological uptake. So the patient is advised to follow a specific diet, especially the low carbohydrate and high fat diet. 1 second. That's it. So the different techniques which can help assessing myocardial inflammation. So these are the few images which you can see there is no uptake in this, and if you can see there is a focal uptake in the basal septum, and then there's moderately increased uptake. And one of the advantage of doing PET is you can have the extra cardiac sarcoid information, where you can take the histopathology, you can have the histopathological diagnosis instead of doing endomyocardial biopsy. So you can see the sensitivity and specificity of these studies, which have quoted very high sensitivity and specificity for FDG PET assessing myocardial inflammation. Thank you. So the pitfalls, the verdict, the basic idea is whether the SPECT can replace PET. As I have discussed earlier, because of the logistic disadvantages of the PET and it not being widely available, the 2 minutes half-life of oxygen or 10 minutes half-life of the ammonia, which needs an all-site cyclotron, they are not, it's difficult to replace SPECT as of now, even with the significant advantage of quantitative PET over SPECT. Thank you.